Adu, you can start.
Okay. Good evening, everyone. My name is Dr. Sadruddin, and today we'll just do a rapid overview of the gastrointestinal system as well as the cardiovascular system. So we will focus more on the history-taking part first, and then we will quickly brush through the abdominal exam as well as the cardiovascular exam. So the objectives of this rapid review is, number one, you need to take a good focused gastrointestinal history for the most common presenting symptoms. And this is because around 70% to 80% of the diagnosis just comes from the history itself. Number two, you need to identify the red flag symptoms that require urgent referral. And then the last objective is to differentiate symptom patterns to narrow down your differential diagnosis. So the most common symptoms, the most common gastrointestinal symptoms, you can either have upper GI gastrointestinal symptoms, the symptoms coming from the lower gastrointestinal tract, as well as the hepatobiliary system. So some of the symptoms patient can present within the upper gastrointestinal system includes dysphagia, which means difficulty swallowing, or odynophagia, heartburn or reflux, dyspepsia, haematemesis, which means vomiting blood as well as vomiting. And the lower GI symptoms include diarrhea, constipation, you can have rectal bleeding, you can have Melaena stools, which means basically black tarry stools, as well as abdominal pain or abdominal distension. So presentations of the hepatobiliary system, you can have patients presenting with jaundice, pruritus, maybe right upper quadrant pain, weight loss or anorexia, pale stools or dark urine. So what are some of the red flag symptoms that once you see, you should have a high suspicion for malignancy? And this is in especially patients more than 55 years, or in a patient who has a new onset of, these symptoms that is less than 3 months, and this require urgent referral. So the first thing I want you to pay attention to is dysphagia. Dysphagia is not a symptom that you see in all people. So just pay attention to any patient who presents with dysphagia. The other one is new onset abdominal pain that is persistent for weeks and is not responding to any medication. Number three is rectal bleeding, which is a key sign of colorectal cancer, especially once you see rectal bleeding in a very old person, more than 55 years, that is mixed with stool, you should have a high index of suspicion of colorectal carcinoma. The other one is the loss of appetite, especially with other symptoms, as well as new onset dyspepsia that is lasting for quite a number of weeks. The other one is change in bowel habits, whether you have diarrhea, constipation, or feeling of incomplete evacuation. The other one is unexplained weight loss because it will lead to you broadening your differentials to systemic diseases and malignancy. The other one is iron deficiency anemia, especially in non-menstruating women or even in men. So let us look at this case scenario here, where you have a patient who has dysphagia. So this is a 62-year-old man who presents with a 6-week history of difficulty swallowing solid foods. The other thing is that he has lost 5 kg in weight. So what questions would you ask to characterize his dysphagia? So the first thing you need to know is the onset and duration. So whenever a patient comes with dysphagia, always ask about the onset and duration. When did it start and how long has it been? So we can see this patient is quite chronic, almost about 6 weeks. And then you need to ask yourself, dysphagia, is it to solids, to liquids, or to both solids and liquids? Because if you have dysphagia to solids, that is most likely dysphagia because of an esophageal carcinoma. But if you get dysphagia to liquids initially first, the person says, I'm able to swallow food, but then I'm not able to swallow liquids very well, that leads you to think of neuromuscular disorders. The other one is associated symptoms. Whenever you have associated symptoms like maybe weight loss, fever, night sweats, it can point you towards malignancy. Check for any other red flag features that we mentioned in the slide previously. So let us look how ask questions can lead you to diagnosis. So it's going to be maybe a stricture or a cancer, or if it is sudden in terms of timing, you can see the differentials now become different. It can be maybe a foreign body that is lodged stack bolus of food. The other one Is it progressive or intermittent? Any dysphagia that is progressive, any difficulty in swallowing that is progressive over weeks, it will lead you to differential of malignancy, especially esophageal carcinoma. The other one is maybe you have dysphagia. Maybe is there you always ask yourself whether there is any associated symptoms. For example, is there any regurgitation or reflux? Because whenever you have dysphagia that is associated with reflux, you start thinking of gastroesophageal reflux disease as one of your differentials. The other thing is the point I mentioned earlier. Whenever you have dysphagia to solids, fast more than the liquids, it's most probably obstructive secondary to maybe esophageal cancer or even esophageal strictures. But then if the liquids, you have difficulty swallowing liquids rather than the solids, that could be neuromuscular disorders like stroke and even achalasia cardia. So you can ask maybe symptoms like difficulty swallowing saliva, weight loss and anorexia. Always ask about the red flag symptoms where you can suspect cancer, especially when someone has weight loss, fever, loss of appetite, anorexia, and those kind of things. So differentiate dysphagia with odynophagia. Odynophagia means painful swallowing. And painful swallowing maybe because there's an inflammatory process happening in the esophagus. Maybe there is esophagitis. You can get esophagitis secondary to um, drugs, which is known as pill esophagitis, or even candida, especially in immunocompromised patients. So the other one is the other common presentation patients will present with is heartburn and reflux. So just let me. Sorry. So just to mention, the difference between upper GI and lower GI is something we call the ligament of Treitz, if you remember in your anatomy, which differentiates the third part and the fourth part of the duodenum. So there's this suspensory ligament of Treitz, and anything proximal to it will is known as an upper GI source, and then anything distal will be lower GI source. So let's continue. So you have a 45-year-old woman who reports a burning sensation in her chest. So what specific questions help characterize these symptoms? The patient comes to you, she tells you, I have a burning sensation, I have maybe some discomfort, maybe some form of some chest pain. So how will you distinguish it from cardiac pain? So think of it, think about the questions you'll ask maybe in 30 seconds. So some of the questions you can ask is related to timing and position. What is triggering the pain? Is there any relation to meals, exercise, breathing? Is there what makes the pain or the discomfort go away? Is there any relief? Is there any medication or any adjustment that the patient does to make sure the pain goes away? And you have to differentiate any patient who comes with chest pain. That pain could be cardiac pain. It could be pain coming from the gastrointestinal tract, and it could be pain coming from the respiratory tract. So you have to differentiate with all other types of pain. So let us look at pain that is associated with, or chest discomfort associated with, the gastroesophageal system. One, when you look at the timing, the patient will tell you it's worse while lying flat at night, or bending, or even stooping. And this is classic gastroesophageal disease. The other one, you can see there are some certain medications that can exacerbate the pain. And the good example is the calcium channel blockers. The other one, you find that when the patient takes antacids, the common over-the-counter medication, the antacids, it's relieved. And that is most likely gastroesophageal reflux disease. But if it's not relieved via antacids, You can think either cardiac pain, respiratory pain, or maybe a typical pain. Maybe there's a certain an underlying suspected malignancy. The other thing you can ask is what makes the pain worse. Maybe you can find that the pain is worse, especially in relation to certain meals. The other one is they will have a bitter or sour taste of like the acid because of the regurgitation. And this distinguishes it from angina, the chest pain related to the cardiovascular system. The other one you need to ask yourself, is the pain exertional? Like when the patient is engaged in doing something or any activity, it becomes worse, or is there any radiation to the arm? So if there is no association, that is probably heartburn and reflux. But if there is, it could be a cardiac cause that you must exclude it. So please ensure that you always ask the questions and rule out any chest. So next, the other symptom that the patient can present with is vomiting. Maybe vomiting food. It could be projectile or non-projectile. You could also have haematemesis, which is vomiting blood. So let's look at this patient. So there's a 55-year-old man. You can see his age. He presents with 3 episodes of vomiting. The vomit he describes it as dark brown, which appear to be coffee grounds. He feels dizzy. So how are you going to take this, history? What are the key questions you're going to ask? In as much as, you have to ask a lot of things. There are specific things that once you ask, the reason I'm doing it in terms of question and answer is because I want you to be like active learners. I just don't want to go through, how to clerk a patient with vomiting. Think, ask yourself, what are the key questions you're going to ask about this vomiting? And what does the coffee ground vomiting indicate? So take a few seconds to think about it. So number one, the first thing you always need to describe is the vomit. Apart from that, you have to describe when has it started, how long has it been, how many episodes, what are the contents. The other thing you need to describe is any associated symptoms. Was there any nausea, any diarrhea as well? And you also need to differentiate vomiting blood from hemoptysis. So let us look at the content of the vomiting. What does the coffee ground vomiters mean? So number one, remember the ligament of Treitz? Remember that ligament I showed you? There's also uh, in the second part of the duodenum, it is where normally the bile opens through the ampulla of Vata, and bile is produced in the liver, stored in the gallbladder, and through the cystic duct, and the bile ducts, they join to form the ampulla of Vata. I mean, they join and open in the ampulla of Vata, and bile is released into the small intestines, especially the duodenum. So anything proximal to where the bile is released, you will have non-bilious vomiting. In when you found no blood is kind of this feel maybe some fresh blood is- maybe you can think of maybe the other one you need to ask about the So the next symptom, remember we were talking about vomiting. You have to ask yourself any relation to meals. Does eating make it worse, or is it worse with feeding? So, for example, so you might have a patient who is vomiting maybe hours after meals. That could be pointing you towards maybe an obstruction. The other one, I told you need to differentiate between hematemesis and hemoptysis. Remember, hemoptysis is blood that is coughed. It could be. And what can give you pointers that there's hemoptysis or hemoptysis? Because hemoptysis, mm, hemoptysis is blood that is coughed. It comes from the respiratory system. What are pointers that could tell you this is hemoptysis and this is not hematemesis? Number one, hemoptysis, maybe there could be an associated cough. The other thing is there could be mixed with sputum. So once you see that the blood is mixed with sputum, you know, oh, this is blood coming from the respiratory tract. The other one is hematemesis. And hematemesis means now blood coming from the gastrointestinal tract, especially uh, from an upper GI source. So what can give you pointers hematemesis? Number one, it is they could be an associated nausea, maybe loss of appetite, basically gastrointestinal symptoms. The other thing is like you need to quantify the vomit. You have to ask the frequency, the volume, what amounts, you know, estimating the volume, especially maybe by using a cup, how many cupfuls, just the normal cup. Because copious vomiting, the patients have a risk of dehydration and electrolyte disturbances. For example, because they vomit too much of their acid, they become alkalosis, and that is known as metabolic alkalosis. And it can be used to, the situation can become worse. The patient can become so dehydrated and the patient can be hemodynamically unstable. So you need to, whenever you ask a patient about vomiting, differentiate, is it hematemesis or is it hemoptysis? What are the contents, associated symptoms? Always scan for red flags, any change in bowel habits or any associated melena, because once you have an melena, it confirms that there is an upper GI bleed and the patient has to be managed. The other thing I told you, what makes the vomit worse? What makes it, you know, better? Any relieving symptoms? What are the exacerbating factors? Differentiate between hematemesis and hemoptysis, and always estimate to assess for any hemodynamic instability. So let us look at this patient now who presents with melena. He tells you, we have a 68-year-old patient who just says, I have dark, tarry, foul-smelling stools for 2 days. Also, she reports bright red blood on the toilet paper occasionally. So whenever you see blood coming out of place where it's supposed to come out from, that is always a red flag. So whenever she has, first of all, she has melena stool, which is dark stool. So what does that mean? Maybe there is some form of digestion of blood. Upper GI reports bright red blood. Remember, you can have bright red blood, you can have bright red, you can have blood mixed with stool. So bright red blood, especially when you use the toilet paper, it indicates maybe fresh blood around the anal area. And the most likely cause is hemorrhoids. But then you find someone is passing stool that is mixed with blood. Remember, it means that that stool is stained with blood from the lower GI. And the most common diagnosis is colorectal cancer. The most common, you should have a high index of suspicion for colorectal cancer. So what questions would you ask to distinguish pneumonia? So number one, you can see melena. Melena stool refers to the black tarry, sticky, shiny, smelly stools. And it's very black. You can't miss melena stool. Okay. And why are they melenas? Because the blood is partially and denatured by gastric acid. Image on the left, those dark tarry stools, it could be from an most probably up. So once you see the bright red blood mixed with stool, you should suspect that this is coming from most commonly the rectum or an anal source. And what is the if it's bright red blood, it means it could be a hemorrhoid. But if it's blood mixed with stool, your differential should be most likely pointing to colorectal cancer unless proven otherwise. So that's the take-home message. So look at the patient's words. They're saying it's just blood after defecation, it's just blood, but the stool is not mixed with blood. That's a hemorrhoid, probably. But if it's blood that is mixed with stool, it means it's from a higher source, and that is probably cancer, colorectal cancer. So let us look at now constipation and maybe change in bowel habits. So we assume someone is constipated if they have less than 3 bowel movements per week. Like you're going to, maybe I'm referring to defecation. You have defecation less than 3 times per week. Maybe patient complains that the stool is hard, and the patient complains that there's some form of straining when things stool. So let us look at this question. There's a 60-year-old male teacher. He comes to the wards. He reports increasingly constipated over the past 8 weeks, passing stool only once or twice a week. He also feels that he hasn't emptied his bowel. So what are the history you would take in a patient who just presents with constipation? And what does the sense of incomplete evacuation suggest? So look at the age. It's a 60-year-old male, constipated over the past 8 weeks. So it means this is something that is chronic and it's developing. Sindio? So apart from saying the onset, the duration, what are some of the questions you would ask? One of the things you could ask is the type of stool that he is removing. the caliber of stool. Is it pencil-like? Is it the normal stool? Is there any change in the stool character? There's something called the Bristol stool chart. Uh, you can find it, and then you can tell the patient to point. You can find this chart in your Hutchinson's. The other thing you can always ask about the danger signs. Is there any blood in the stool? Is there any weight loss? Is there any abdominal pain? Is there any vomiting? Eh? Is there any drugs? You need to take a good drug history. Is he smoking? Is he taking any alcohol? Are there any systemic signs like fever? Rule out all the red flags. This is Bristol stool chart I was talking about. You can see the normal stool is number grade stool type 3 and 4. These are the healthy stools, and the others are a bit, there could be some pathology. So, for example, the red flag is this thing has been there for 8 weeks. So you should have your antennas very sharp and high to detect like, hey, this is chronic. We must exclude colorectal cancer. Can ask about the stool character because the stool type of people with colorectal cancer, because the cancer is spreading and it's enlarging, it causes maybe the lumen, the lumen a bit narrow, and the stool becomes now, now the stool is passing a very narrow space, so they'll be slightly elongated and looking like pen diet. His intake, especially maybe his intake could also be constipation, not malignant. For diets that are very low in fiber, especially processed foods. The other thing is he's complaining of the sense of incomplete evacuation. That sense of incomplete evacuation, in medical terms, it is known as tenesmus. And this suggests that there could be an underlying rectal cancer, and urgent assessment is needed. Number two, always ask about bleeding in any person with constipation. Number three, also do a very good, proper past medical and surgical history. Did he have any surgery? And the medical history, what are the current medication he's using? For example, So we have this 28-year-old woman who has loose stools. She notices blood and mucus in the stool and is woken from sleep at night. Remember, she's been having diarrhea she has 3 episodes of diarrhea a day for almost about 3 months. She notices blood and mucus in the stool and is woken from sleep at night. So what are the 4 key questions that can characterize this diarrhea, and what does this presentation suggest? So you always have to rule out any malignancy, any constitutional symptoms, systemic symptoms like weight loss, anorexia, night sweats, any change in bowel habits, especially the stool caliber. You have to always rule out. So, but what does this presentation suggest? Like she has loose stool, blood in the mucus, blood and mucus in the stool, and is woken from sleep at night. So there's this specific diagnosis. So you need to ask yourself, is it acute? See here, it's chronic. So number 2, we can see there is blood and there is mucus. The other one is it's nocturnal. It wakes the patient. Number 3, you have to ask yourself, is there any associated weight loss? Because when you lost weight, there's the result of maybe malabsorption. Okay. So let us look at this presentation. It's a very unique one. So whenever you have chronic, bloody, nocturnal diarrhea, you always assume that it could be as a result of inflammatory bowel disease until proven otherwise. And inflammatory bowel disease, we have 2 types. We have in Crohn's disease and we also have ulcerative colitis. So let us look at the types of diarrhea. We can have inflammatory diarrhea. And the clues include blood and mucus. Another sign that can point to there is inflammation is fever, and there might be abdominal pain. So go and read on ulcerative colitis and Crohn's disease and how they vary in their presentation. Ulcerative colitis is it's more of lower GI. However, Crohn's disease affects any part of the gastrointestinal system from the mouth to the anus. There's one that is transmural inflammation, and there's one that just affects the submucosa. So go and read on those. Number 2, you can have dysmotility. For example, you just have irritable bowel syndrome. Here, there's no blood. The pain is improved by defecation, and it does not wake the patient. So this is just like a irritable bowel. You just have some discomfort to go to the washroom and you're okay. You can also have diarrhea because of malabsorption. For example, in celiac disease or specifically in chronic pancreatitis. Because in chronic pancreatitis, there is absent production of the pancreatic juice that is very key in absorption in the small intestine. So if you don't have that pancreatic juice that is produced, of the pancreatic enzymes, you get something called steatorrhea. So whenever you see fat in the stool, you should think about pancreatitis as one of your differential. They also have weight loss because of the malabsorption. And because it is also needed in iron absorption, you can have also anemia. The other one, you can have diarrhea that is secretory. You're not eating anything, you have that. It's called osmotic diarrhea. Like you find that the luminal contents, maybe pool water, or there's a problem with the villi that make them secrete water instead of absorbing water. So the clues, secretory diarrhea normally has very large volume, and there's no change with fasting. For example, you tell the patient to fast and you see if the diarrhea improves. Even with the fasting, there's still diarrhea, and there's copious amounts of stool production. So the other key symptom you need to know is abdominal pain. Because abdominal pain, it could be signs of an acute abdomen, and you need to know all the differentials of an abdominal pain. So let us look at this 52-year-old man. He has severe epigastric pain radiating to his back, occurring immediately after meals. He leans forward to get some relief. So whenever you see epigastric pain radiating to the back, what do you think of? And remember, for pain, always use the Socrates, where is the site of the pain, the onset, the character, radiation, associations, timing, what are exacerbating and relieving factors, severity. Always also try to always rule out the red flags in your HPI. So, for example, this is very specific. Whenever you see epigastric pain radiating to the back, occurring especially after meal, that is very classic for an acute pancreatitis. So these are the various abdominal pain patterns that is related especially to internal medicine. You can have peptic ulcer, which is epigastric, and it's normally a burning or gnawing pain, and it radiates to the back, and it's meal related. Peptic ulcers, there's a certain type of ulcer, peptic ulcer. It is worsened by meal, and there's one that is improved by meal. You need to know, is it the duodenal ulcer or is it gastric ulcer? It can wake the patient at night and it's relieved by antacids. So here we can have pain from the lower GI, either periumbilical, you can have suprapubic. The character is normally colicky. The radiation can be variable, and this is mostly relieved by bowel action like and bloating. However, in the lower GI, we can also have, always rule out also in female patient, always rule out obstetric and gynecological causes of pain. For example, they might have pelvic inflammatory disease. They might be having, ovarian torsion. So in a female patient, always put your differentials very wide. So you can also have the one we talked about, pancreatic pain that is in the epigastric area. It radiates to the back, and you find it immediately after the meal. It comes immediately after you take some food, and it's relieved by sitting forward. And this is very severe. You can also have pain that is they can point you towards the renal system. For example, it will be in the flanks or the loin, and sometimes it radiates to the groin. It's severe and colicky, and it radiates from the loin to the groin, from the flanks going towards the scrota, the labia, and those areas. It's very severe. Always try to ask about, hematuria, any frothy urine, any change in color of the urine, maybe is it dark, and those kind of things. You can also get biliary pain, and this is pain in the right upper quadrant. It is severe. It is colicky. Colicky means it comes in cycle. It comes this minute you have pain, after 5 minutes you get relief, and then it comes back. It comes in cycles. That's why it's called colicky. You might have radiation to the right shoulder. It can be accompanied by nausea, and it can be after fatty meal. Then you can get functional pain or just an irritable bowel syndrome pain. It can be anywhere. It's colicky. It's no radiation. But then the good thing with this pain, it's relieved by defecation, and there are no red flags. So I just wanted to highlight the difference between gastric ulcer and duodenal ulcer. Gastric ulcer, remember the word gastric, it's in the stomach lining. Duodenal ulcer, it's in the first part of the duodenum. So the difference, you can go through this table at your own time, but just know that gastric ulcer, it is worsened by meals and occurs shortly after eating. So once you eat, you start feeling the pain. But duodenal ulcer on the other side, it is relieved by meals. So you get relief once you eat the meal. But however, 2 to 3 hours after eating, it wakes you at night. You start feeling pain, and that is specific for duodenal ulcer. The other thing, what is the main cause of duodenal ulcer and what is the main cause of gastric ulcer? So the most common cause of gastric ulcer, anyone? Most common cause of gastric ulcer is, so you have to get a very drug history. So the most common cause is the NSAIDs, the non-inflammatory drugs, but duodenal ulcer, the most common cause is H. pylori. So those are the things that I just wanted for these. So the presentation could be abdominal distension. Remember, abdominal distension could be any of the 5 Fs. I know everyone knows this by now. It could be fluid, it could be flatus, it could be feces, it could be. So you need to ask yourself, is the distension symmetrical or is the distension asymmetrical? So if you have a symmetrical distension, what are the causes of a symmetrical distension? So causes of symmetrical distension include obesity. You can get ascites, for example, in patients with end-stage liver disease, heart failure, nephrotic syndrome, or some malignancies. You can also get symmetrical distension from pregnancy. But what are the causes of asymmetrical distension? Once you see the abdomen, and then you see the abdomen, when you do maybe an abdominal exam, you notice that, the abdomen, there's a distension, but it is asymmetrical. So what are the things you can think about? So number one is hepatomegaly, especially with a large right, especially in the right upper quadrant, splenomegaly, when you have a left side bulge. And then sometimes you might have a large intra-abdominal mass or a malignancy or even a lymphoma. So always think about the distension in terms of symmetrical or asymmetrical. So you must know the causes of hepatomegaly. So this one, you'll get it in the presentation. You must know the causes of hepatomegaly. This one is a must know. The other thing you need to know is causes of splenomegaly, especially causes of massive splenomegaly here. Causes of massive splenomegaly, especially in our setup, it could be Kala-Azar, which is leishmaniasis. The other causes could be CML, which is chronic myeloid leukemia, myelofibrosis, Gaucher's disease, thalassemia major, and all those kind of things. So make sure you know the causes of hepatomegaly and splenomegaly for exam. So the other thing you always have to ask about in any GI is any weight loss or anorexia, loss of appetite. So weight loss can be as a result of reduced intake. It could be as a result of malabsorption. It could be as a result of systemic disease. And I've listed all the causes here just as an overview. And we talked about reduced intake, for example, dysphagia, vomiting, malabsorption. For example, you can have celiac disease, chronic pancreatic disease, or pancreatic exocrine insufficiency. We talked about inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease. Patients who under any form of resection, especially patients with maybe a malignancy where the bowel is resected, they can have a short gut or small short gut syndrome. Like they have quick evacuation of the food contents in the gastrointestinal tract, so they don't get enough time for absorption. So the other thing is systemic diseases. Any cancer can lead to loss of appetite and eventually weight loss. Chronic infections, especially TB, especially in underdeveloped countries. Thyrotoxicosis, or especially hyperthyroidism, as well as Addison's disease. So the other key symptom you need to know is jaundice. We have a 70-year-old man who presents with progressive jaundice over 3 weeks. So remember, progressive jaundice. This jaundice has been worsening. He has pale stools, dark urine, and a severe itch. He has lost 6 kg in weight. So this is a serious jaundice. So what are the 3 questions that differentiate the type of jaundice? You need to ask yourself the same things. Whenever you have a patient with jaundice, always ask about, is there any itchiness? Because itchiness leads to a specific diagnosis of obstructive jaundice. The other thing you need to ask yourself is the urine and the stool. Obstructive jaundice normally it's specific. It has dark urine. It's the only jaundice that has dark urine and pale stools. And the other question is urine, stool, and any itch I mentioned earlier. So these are the types of jaundice. It could be prehepatic, it could be hepatic, or post-hepatic. Okay. So prehepatic jaundice means anything before the liver. So the most common cause is hemolysis, you can see, for example, or sometimes you might have Gilbert syndrome. Hepatic jaundice means the pathology is inside the liver. So think of anything that affects the liver. You can have hepatitis secondary to hepatitis A, B, C, D viruses. You can have autoimmune hepatitis. You can have drug-induced liver cirrhosis, liver cancer, secondary liver cancer, and all those kind of things. Any metastasis to the liver can also cause hepatic jaundice. Post-hepatic here, we are talking about the bile salts. Okay, we're talking about the bile salts because what happens in obstructive jaundice, bile is not deposited in remember we talked about the ampulla of Vata. It's not going to the small intestine. So what is it happening? It's recirculating back to the bloodstream, and the body finds a way of depositing the bile salts on the skin. Hence, you get the itch. That is why post-hepatic jaundice, which is also known as obstructive jaundice, will always present with one, because the bile is blocked, they will have pale stools and they will have dark urine. The jaundice will be more severe in these patients. The bilirubin levels will be very high. And as a result, what are some of the common causes of obstructive jaundice? One, you always need to rule out head of pancreas cancer, pancreatic head cancer. Number two, one of the most common causes is gallstones. You might have primary sclerosing cholangitis and all those kind of things. You can also get cholangiocarcinoma. So always differentiate the type of jaundice just by the presentation. If there's, or whenever you have a patient, so in short, I'm saying whenever you have a patient with jaundice, always ask about whether there's an itch, whether there is pale stools, and whether there is dark urine. If there are none, it could be prehepatic or hepatic. But if it's obstructive jaundice, they will almost always present with dark urine and pale stools. So this is the rough anatomy we're talking about. We have the right and left bile ducts that comes and joins to form the common bile duct. And then bile is produced and stored in the gallbladder. and the gallbladder connects to the common bile duct through the cystic duct, which now forms the bile duct. Now the common bile duct will come and join with the pancreatic duct to form and exit through the ampulla of Vata in this part of the duodenum. I think it's the second part of the duodenum. And remember, when you have obstructive jaundice, it means you have maybe pancreatic head tumor, you have a gallstone, you can have cholangiocarcinoma, cancer of the ducts that narrow the lumen, and hence you have obstructive jaundice. So bile is not coming to the gastrointestinal tract. So the first thing you'll have is the stool will be affected. You will get pale stools. There are other ways to deposit and exit the body, and it comes and deposits in the skin, just in layman terms, and then you get that itch or pruritus. So the other thing you need to know is the peripheral stigmata of chronic liver disease, but this one you will cover in abdominal exam. So what are the key takeaways in GI history taking? Number one, always use Socrates for abdominal pain characterization. Focus on your HPI. Always ask about red flags in any patient. Dysphagia that is for solids, obstructive, and if it's worse for liquid, you think about neuromuscular. Bloody diarrhea that is waking the patient at night is inflammatory bowel disease, especially ulcerative colitis. It could be ulcerative colitis or Crohn's disease. And the three questions for jaundice you should always ask about is the urine color. In obstructive jaundice, it will be dark, and the stool color will be pale, and there'll be a presence of an itch. Okay, so don't get that right. And then the last thing is a good history alone can lead to the diagnosis in 70 to 80% of the cases before examination. So let me quickly share the next presentation. We'll quickly go through abdominal exam in just about 5 minutes. I know most of you know the abdominal exam, but we'll quickly go through it. Yeah. So we're going to talk about the full gastrointestinal exam. So the full gastrointestinal exam, it's not only the abdominal exam, it involves the peripheral findings. So what is the general approach that you're supposed to do? So you need to, the mnemonic is, you do your gripe first. Always do your basics, like greet the patient, create rapport, introduce yourself as you're explaining, what the examination entails, seek permission, and you expose the patient. And what is the ideal exposure for abdominal exam? It should be from the nipples. The nipples up to the knee or mid-thigh. But because of privacy, you just use a draping and ensure you just expose up to the waistline. And you ensure that, the patient is covered well for privacy. And the patient should be positioned supine. The leg should be straight and uncrossed. The head should be at least at 45 degrees and arm should be by the sides, just basically in an anatomical positioning. So for example, you want to do an abdominal exam, you find a patient, the legs maybe is bent or the knees are bent. What does that tell you? Maybe it could be a silent pointer towards some peritonitis. So after that, you've exposed your patient, go to the foot of the bed, you just describe the patient's age, is the patient sick looking or not, just general inspection of the patient. Is the patient in any comfort or any distress, any respiratory distress? Is the patient alert or appears confused? Because a patient who's confused could be patient with hepatic encephalopathy. The other one, you can look at the general appearance of the patient, whether the patient has obvious pallor, has any obvious jaundice, maybe has hyperpigmentation. For example, hemochromatosis, you can find abnormal hyperpigmentation of the skin. Maybe you can also talk about body habitus. Maybe you can see the patient is obese, or maybe the patient is wasted or cachexic. And the patient who's wasted or patient who has cachexia, it points towards malignancy or advanced liver disease. So the other thing, at the foot of the bed, number 2, it describes the objects and equipment around the patient. So most importantly, things related to the gastrointestinal systems or any other systems for that matter. So the image on the right here, you can see here is clearly, there was a stoma bag here, but then this is a stoma, like an outpouch of the bowel. So we can have an ileostomy, which is found in the right iliac fossa most of the times, colostomy in the left iliac fossa, or even urostomy, which can be also found in the right iliac fossa. But how will you know which type of stomy it is? It's the content. Colostomy will have hard stools. Ileostomy will have, semi-liquid stools. Urostomy will have a urine. So the other thing you can comment is any nasogastric or nasojejunal tubes. If there are any drains, not the color, the blood, whether it's bloody, it's pus, is it bilious, is there any chyle, and also indicate the amount. Any IV lines, is the patient in any total parenteral nutrition, catheters, oxygen, and the oxygen delivery method. You can even read the liters per minute, any diapers for that matter. So this is just an image talking about the types of stomies. So after that, if you've done your gripe, you've created rapport with the patient, you've exposed, you've gone to the foot of the bed, you describe the patient, you describe the surroundings, you look at the hands. And there are some signs in the hands that can show you there is an underlying gastrointestinal disease. So number one, you can look for is pallor. You can see here clearly the patient's arm on the left here is pale, and the examiner's hand is, there's adequate circulation. And you can see here there's pallor basically. Number two is palmaerythema. Palmaerythema means redness of the palms, and this could be an underlying liver disease. It's peripheral stigmata of liver disease. The other one is koilonychia. And koilonychia is specific to what? Iron deficiency anemia, or spooning of the nails. The other one is leukonychia, which is whitening of the nails. Could be it's also a peripheral stigmata of chronic liver disease, as well as Dupuytren's contracture. You get contractures of these tendons. The other one you can have is finger clubbing, and whenever you do finger clubbing, always grade the grade of finger clubbing. Is it grade 1, 2, 3, and 4? But finger clubbing is not only liver disease; it could also be as a result of many other diseases. So the other thing you can check for is the flapping tremor or asterixis, because this could indicate that there is some form of chronic liver disease. Another thing which can be related to another system is it could be a sign of CO2 retention or cardiorespiratory illness. So the other thing you can check for a few things in the arms. So you can just check for three things maybe that I've highlighted in bold. Maybe easy bruising. Easy bruising means there could be an underlying coagulopathy. And remember, in liver cirrhosis or end-stage liver disease, the liver does not produce a lot of the coagulation factors. It's the functionality of the liver markedly reduces. The other one you can check for is the itchiness or the excoriation, or whenever you see pruritus. It could be because of obstructive jaundice secondary to something, maybe pancreatic head cancer, maybe cholestasis, maybe gallstones, and all those kind of things. The other thing you can check for is maybe acanthosis nigricans, which is a sign of insulin resistance. So these are the three things you can see here. There's easy bruising under the skin. There's some form of hemorrhage. This is a patient who's been scratching themselves. Sometimes they may be red or white. And then this is a patient with acanthosis nigricans. So in the eyes, you come to the eyes now, head to toe. What are some of the signs you can check for? You can check for jaundice. You can see here there's some scleral jaundice. You can find maybe pallor. Signs of hyperlipidemia, for example, you can find that there's corneal arcus. And here is jaundice. And it's a key exam question. You need to know what are the causes of prehepatic jaundice and how is it different from hepatic jaundice and post-hepatic causes. So you go through this slide, and here I've attached a video talking about the jaundice, the types of jaundice, what's the treatment, and the pathophysiology behind it. So still in the eyes, apart from pallor, jaundice, and signs of hyperlipidemia, you can also find this sign, which is xanthelasma. This is also a sign of hyperlipidemia, elevated triglycerides and those fats in the blood. So you can also have maybe Kaiser-Fleischer rings, and this is it's very rare to see, but this is it's a very rare condition to see in the eyes, and this is because of abnormal copper deposition, and this is secondary to Wilson's disease. In the mouth, what are some of the things you can check related to the gastrointestinal system? You can have angular stomatitis, which could be a sign of anemia. You can have glossitis in the tongue. You can have oral ulcers. Oral ulcers could be a sign of what? Especially what? Inflammatory bowel disease, especially Crohn's disease. I told you Crohn's disease can happen from the mouth to the anus. However, ulcerative colitis has preference for the lower gastrointestinal system. So you can find signs like oral candidiasis, pallor in the mouth and in the tongue. This is central pallor, and you can also have jaundice. So in the neck, you can just scan, especially the anterior lymph nodes of the neck. You can have maybe an enlarged supraclavicular nodes. This, especially a left enlarged supraclavicular node, is known as a Virchow's node. It comes in MCQs, and this points to a gastric or intra-abdominal malignancy. So you can also have maybe spider nevi, and these are most commonly found in the chest. It could be innocent in women who are pregnant, in normal individuals. But then if you have more than five, that the number is five, according to Hutchinson's, it's normally pathological. The other finding in the chest, the second finding in the chest is gynecomastia. If you have gynecomastia in males, especially, it could be as a result of end-stage liver disease or some drugs that don't cause gynecomastia. For example, spironolactone, aldactone, and those kind of drugs. So once you've done the peripheral signs, now comes the abdominal exam. Remember, we've done the peripheral signs. We started with the hands. We checked for three things: bruising, excoriations, acanthosis nigricans. We looked in the eyes for pallor, jaundice, and signs of hyperlipidemia. We checked the mouth for oral ulcers, oral thrush, glossitis, and all those kind of things. In the neck, we just scanned for what? We scanned for maybe a left supraclavicular node. Just palpate, quickly palpate if you're doing a full gastrointestinal exam. Then in the chest, you just check for any spider nevii and gynecomastia. But then if you're told to do an abdominal exam, remember that is what I'm talking about is a full gastrointestinal exam. Abdominal exam, you just do inspection, palpation, percussion, and auscultation. So abdominal inspection, you from the foot of the bed, you just for three things. Number one is the shape of the abdomen. Is it round? Is it flat? Is it scaphoid? Symmetry. Does the abdomen appear symmetrical? Left is a mirror image of the right. Is there any flank fullness? And if you notice any distension, you should have your differentials ready that we talked about. It could be fat, and the distension always note. The first thing should be, is it symmetrical distension or asymmetrical? Then once you're at the foot of the bed, come to the right side of the bed and you look at the umbilicus. That's the second thing. Number two is you check whether the abdomen is moving with respiration. An abdomen that is not moving with the respiration is known as a silent abdomen. It could be an underlying peritonitis. And then the S, you check the skin. In the skin, it's where you check for scars, stria, veins, hernias, stomas. You can have specific signs of pancreatitis. For example, you can have Cullen sign and the Gray Turner signs. And you can also check for masses and always describe masses in detail in 10 aspects: the size, shape, surface, site. In which site is it, in the which quadrant, or which, according to the 9 regions of the abdomen, in which region? Okay, the surface, consistency, any skin changes, is it pulsatile? Always describe it in detail. And this is how you're supposed to describe a mass in any exam. So these are the 9 abdominal regions. So just do a quick recap of the abdominal regions. These are some of the scars and some of the names of the scars that you can get. For example, you can see here this scar number 1 here is subcostal, is just below the rib. Scar number 3 is a midline scar. Scar number 2 is paramedial. So these are the types of hernias you can get according to the regions. You can get incisional, maybe after surgery. You can get an umbilical hernia, epigastric hernia, and all those kind of things. So in the skin, what are some of the signs you can check? You can get purple stria. This is especially in Cushing's syndrome. You can get white stria. White stria, these ones are innocent because of maybe stretch marks secondary to pregnancy, especially if you see it in the abdomen. This is a stoma bag we talked about. This is an example of a hernia. This could be maybe an epigastric hernia. And this is caput medusa, especially in the abdomen. Once you look, you see it revolves around the umbilicus. So this is caput medusa, and this is a sign of portal hypertension. However, you can have veins that are parallel to the midline, and this is mostly seen in inferior vena cava obstruction. You can see portal hypertension, it's central, and it revolves, like it makes networks around the umbilicus. And this is a scan. This is like a CT scan showing like how the caput medusa is, and you can see it's central. But then if you look at the inferior vena cava obstruction, it forms parallel, almost sparing the center quite much. So the 2 signs here, we can have Cullen sign, which is hemorrhage around the umbilical area. Here you can see it's below the umbilicus, and here you can have Gray Turner sign, where you have hemorrhage around the flanks. And these 2 signs are signs of hemorrhagic pancreatitis. So this is just the difference showing between the image on the left is caput medusa secondary to portal hypertension, and the image on the right is distended veins because of inferior vena cava obstruction. So the next thing after you do your inspection, remember you've done your inspection, the next thing should be palpation, and there should be 3 rules of palpation. So number 1, always ask about pain. Number 2, always warm your hands. Number 3, the way the way the student is looking at the patient, always make sure once you examine the patient, always look at the patient's eyes. You keep eye contact so that you check for any wincing. If the patient, is reacting to any painful region, you'll notice in his eyes or his facial expressions. So what do we palpate for? Number one, we do just a light palpation around the 9 regions. What are some of the signs you can see? One is pain or tenderness. Number two, you'll find that the patient tenses the muscles. That is known as guarding. Number three, once you lift your hand up, once you make the contact with the abdomen, there's no pain. But once you lift your hand away from the skin, you get rebound pain or rebound tenderness. And all these signs could be signs of peritonitis. Number three is when you find masses, always describe them in extreme detail. So you do your light palpation with one hand, you can do deep palpation with two hands. Number three, you have to palpate for the organs. Number one is the liver. And the liver, the technique, you always start in the right iliac fossa and you move up during inspiration. The liver expands just 2 centimeters or 1 finger below the costal margin. Anything above that, more than 2 centimeters, that is known as hepatomegaly. The liver, when you palpate, you find nodules that could be cirrhosis or metastasis of a certain cancer to the liver. The other thing is the gallbladder. Gallbladder is very difficult to palpate, but once you palpate and you tell the patient to breathe in, and then there's a sudden stop, and there's a sudden stop in breath or cessation in breathing, that is known as Murphy's sign. And Murphy's sign, remember the gallbladder I showed you? It means there is cholecystitis or inflammation of the gallbladder. However, there's something called the Courvoisier's law, which says you might have painless. You find that the gallbladder is enlarged, painless, and then you have jaundice. Okay, you have a patient with jaundice, and once you palpate the right upper quadrant, there's no pain. It could be pointing towards malignancy. So whenever you hear Courvoisier's law, think of cancer, and most probably cancer of the pancreatic head. Whenever you think of a sudden pause in breathing, once you palpate the right upper quadrant, that is known as Murphy's sign, and that is cholecystitis. So the other organs you always palpate for is the spleen. You start in the right iliac fossa and you move diagonally, and the splenic notch is normally palpable, and the spleen always enlarges towards the right iliac fossa. The other thing, you have to ballot the kidneys or by manual palpation. Kidneys, most of the time, they are unballotable or they cannot be palpated easily. And if they are easily palpated, it could be as a result of maybe polycystic kidney disease or because of enlarged kidneys secondary to an obstruction downstream, or because of a tumor. The other one you need to palpate for is the aorta. If you have an abdominal aortic aneurysm, you will have an expansile mass that is expanding during palpation. The other thing you can palpate for is a bladder, especially in patients who have urinary retention. But ideally, always do palpation for all the organs in exam. So these are just signs of appendicitis. You go through them at your own time, especially in surgery. And I still emphasize on, you need to know the causes of hepatomegaly. It is a must know. And the causes of splenomegaly, especially, you must know the causes of a massive spleen. In our setup, the most common cause is leishmaniasis, and you might even get chronic malaria and the leukemias, chronic myelocytic leukemia. So this is just talking about splenomegaly. The next thing is percussion. So percussion, you have to percuss for the general percussion note is tympanic and the abdomen. Then you have to percuss for the liver span. And how do you percuss it? You always start from the top up, from, let's say, just below the clavicles. You percuss until you feel an area of dullness. Remember, in the chest, it should be resonant. Then once you feel an area of dullness, you mark. And never percuss across the liver. You now start in the right iliac fossa. It will be tympanic, tympanic, tympanic as you go up until a place you will feel dull. And then those 2 points, you measure. And the liver span should be about 12 to 15 centimeters, or not more than 2 centimeters, or 1 finger below the costal margin. Anything above that is hepatomegaly, and you need to know all the causes of hepatomegaly. So the other thing you need to percuss for is shifting dullness and fluid thrill. And the gold standard is shifting dullness. Okay, so always percuss the things I've highlighted here in red, which is the liver span. You need to percuss for shifting dullness to check for any ascites and fluid thrill. Whether the patient has these things or not, always do that in your percussion. Auscultation, what are we listening for? Number one is bowel sounds. You have to listen to 1 to 2 minutes, at least 1 minute. Okay, you use the the diaphragm, the large part of the stethoscope. And it's what is the best place to listen for bowel sounds according to Hutchinson's? It is just to the right and below. Okay, right and below is the best. And normally the bowel sounds are normally 3 to 5 in a minute. They're normally gargling noises, with their low pitch sounds. If you find more than maybe 10 bowel sounds in a minute, you might think of an acute intestinal obstruction. If they're absent, you might think of maybe paralytic ileus or underlying peritonitis. The other thing you can check for is for bruit along the abdominal vessels, and these are the positions of those bruits. You can put your stethoscope just above the umbilicus and slightly to the left for the abdominal aorta to check for any bruit. Renal artery, the right and left renal artery, they are almost in the same position as the right and left iliac artery. You can check for bruit there, and remember you can also check maybe for bruise in the femoral artery. So just to check for any abnormal circulation. So the abdominal exam, remember we've done inspection, we've done palpation, we've done percussion, and we've done auscultation. So it is not complete before you mentioning groin and diarrhea. So what are the things you can check for in the groin? Now here you lift the sheet a bit slightly up, not exposing the patient, but you just look beneath the sheet or beneath the drape. You're checking for any hernias. You can tell the patient to look on the left and cough. You might find an inguinal hernia, and you might even find femoral hernia. So inguinal hernia, it's normally medial to the pubic tubercle, and it's normally above and medial. For example, here, this is where you find the inguinal hernia in this position. But then the femoral hernia, it is normally lateral and below. And the cough impulse always confirms a hernia. You tell the patient, slightly turn your head to the left away from you, and tell the patient to cough. The other thing is a diarrhea. This one you don't do it ideally in exam setup, but you have to mention it. And what are the indications for diarrhea? Number one, we talked about parectal bleeding, whether fresh blood or blood mixed with the stool. Number two, when there is intestinal obstruction, you want to know, is the rectum empty or does the rectum have anything? Or is it filled with, is there any feces? What are the contents of the rectum? Is it air or is it some feces? The other thing is, you want to, when you suspect malignancy, especially maybe when you have a rectal cancer, and also specifically when you have maybe in men, when you suspect maybe prostate cancer. Ideally, the prostate is like, it has the right lobe, the left lobe, they should be symmetrical. It has a midline sulcus, you should feel for it, and it should be smooth and not rough. So the technique is, the patient has to lie in the left lateral position with a lubricated finger. You lubricate your finger, double glove. You check the tone of the rectum, check for any masses. You can examine the prostate, and once you remove, don't throw the glove. Always check for any blood or mucus. Lastly, you check the legs for any bilateral pedal edema. So if you have bilateral edema, that could be three things. Number one, it could be low albumin, secondary to nephrotic syndrome. So you think about, or even secondary to liver disease. Number two, you can have nephrotic syndrome as chronic kidney disease. Number two, you can have chronic liver disease or end-stage liver disease, liver cirrhosis. You can also have low albumin, or you can also have heart failure as a result. So maybe whenever you see someone who has bilateral pedal edema, think of the heart failure. Think of the liver, end-stage liver disease. Think of the kidney as nephrotic syndrome. So these are the key syndromes. We talked about Murphy sign and Courvoisier's law. There's something called the Charcot's triad. Charcot's triad means someone now has pain in the right upper quadrant. Remember, whenever you feel pain, that is not cancer. It's probably inflammation. Fever. Remember, fever is also part of pain and inflammation. So it's an inflammatory process. So the Charcot's triad means you have right upper quadrant pain, fever, and jaundice. Once you have that triad, your diagnosis should be, you should be thinking about ascending cholangitis, inflammation in the ducts. Remember, we talked about Murphy's sign, inspiratory arrest on right upper quadrant palpation, that is acute cholecystitis. Courvoisier's law, I told you, it's cancer. It means you have painless enlarged gallbladder plus jaundice. There's no pain here. So it's cancer, and most probably cancer of the pancreatic head. So you can have Charcot's triad plus two other signs known as, you can have confusion and hypotension. And this is also just a sign of severe acute ascending cholangitis. So this is the second image here is Murphy's sign, inspiratory arrest on palpation of the liver, sudden arrest. This is cholecystitis. So conclusion, always thank the patient once you do the exam, let them cover up and allow them to lie comfortably, wash your hands, and you summarize your findings. So this is a video I've attached on abdominal exam, you go through it at your own time. So thank you, and this finishes the first part of my presentation. If you don't have any questions, we're going to move to the second part now, which is the cardiovascular exam and history. So let me just quickly share my screen. So I hope you've understood. So learn to ask the right questions. I know you've taken a lot of histories, but focus on, the history itself will give you 90%, 70 to 90% of the diagnosis. So let's quickly go through cardiovascular history and exam. Yeah. So these are some of the cardinal cardiovascular symptoms that patients present with. So number one is chest pain. And I told you chest pain, you have to differentiate. Okay. So chest pain, you have to differentiate cardiac pain from the other non-cardiac pains. Is it a respiratory pain? Is it pain coming from the chest, maybe from the lungs? Is it from the heart or cardiovascular pain? Or is it pain coming from the abdomen? We from the gastrointestinal system. So we covered the gastrointestinal system. So the pain will have relations to meals, will be maybe relieved by antacids. Maybe the pain will be coming at night. There's no specific radiation, especially if it's maybe gastroesophageal reflux pain. The key symptom is it is associated with meals. But then this one, the cardiovascular pain, it will be associated with exertion and there'll be some form of radiation. And that's all you need to know. So whenever you have a patient who presents with chest pain in any ward, always ask about meals, always ask about antacids, always ask about is it exertional, always ask about radiation in terms of cardiovascular, and always rule out is it respiratory, is there any cough, any associated cough, any hemoptysis, any haematemesis. So think and ask as many questions as you can. So I don't want you to ask when did it start, has it been progressing, blah blah, all those kind of the basic things. Ask also the specific, in as much as you ask the basic things, always think deep and always be broad in whatever you're asking. You better ask a lot of things and not miss anything, rather than asking very few things and missing a lot of differentials. So for example, you have a patient, maybe in the previous lecture, the gastrointestinal system, you have a patient who has bilateral pedal edema. So I told you it's caused by maybe heart failure, it is caused by chronic liver disease, it is caused by nephrotic syndrome. So always ask about urine, because you want to rule out any nephrotic syndrome. Is there any groin pain or loin pain, pains in the flank? Is there any change in urine color, frequency, the color of the urine, how the urine comes out, the frequency? Okay. Is there any pain in the, when you pain when urinating? So that's how you can rule maybe kidney problem. With liver, always ask about jaundice, right upper quadrant pain, all those kind, loss of appetite, anorexia, trying to rule out as much as you can the liver symptoms. If it's heart, you ask about, because if it's heart failure, you ask about any, paroxysmal nocturnal dyspnea, any orthop. You think of start asking a lot of things. So make sure your HPI is as detailed as possible, ruling out one system over the other. So cardinal cardiovascular symptom, number one is chest pain. So cardiovascular pain, you can have one. Let me just let me put my pointer. So the patient can tell you they are feeling tight, like the chest is being constricted, or a heaviness. Sometimes they describe someone is sitting on their chest, or pressure. And that is classic for ischemic pain. Ischemic pain means blood supply to the heart is compromised. For example, you might have it in stable angina or the acute coronary syndrome. It means there's some form of blockage of blood to the heart. Just know that. You might have tearing or ripping pain. Tearing pain or ripping pain means pain that You feel like someone is ripping you apart, and you feel it mostly, it radiates to the back between the scapula. That is very classic for a pain of aortic dissection. You see, it's still cardiovascular, but then the differential is changing. Someone sitting on you, heaviness or pressure, like sometimes they might tell you an elephant is sitting on my chest. That could be ischemic. Tearing and ripping pain that is radiating to the back, in between the scapula, the wings of the scapula, that's when you suspect aortic dissection. Number two, you can have sharp pain, pain that is very sharp, and it is pleuritic. Pleuritic pain means pain that once you take a deep breath or just breathing in makes it worse. So instead you do what? You take shallow breaths. It means there's some irritation. Whenever you hear pleuritic, it means the pleura, okay? Or the pericardial, the outer sacs are irritated and inflamed. So if you touch them, it's, for example, you have a wound on your skin, on your leg. If I step on that wound, what will happen? You'll feel pain. That is how those sacs react. When you have pleuritis, secondary to maybe a pulmonary embolism or TB, or when you have pericarditis, okay? When you have pericarditis, the outer layer of the heart is inflamed. If you get in contact with the lungs when you're breathing in, remember the lungs and the heart are very close. If you breathe in, lungs fill with air, the lungs come in contact, the pleura come in contact with the pericardium, they rub against each other, you'll feel that pain. So that's pleuritic pain, pain worse by breathing in. So instead, the patient takes shallow breaths. So sharp pleuritic pain, you think of either pericarditis or pulmonary embolism, or maybe anything that can cause, pleuritis or pericarditis. When you think of burning pain in the chest, worsened or maybe relieved by meals or relieved by antacids, what do you think of? That could be gastroesophageal reflux disease, should be one of your differentials. So try to rule out these pains as much as you can. The other one is the location and radiation. Ischemic pain, I told you it is retrosternal, just behind the sternum, and it radiates towards the left arm. Sometimes it radiates towards the neck, and sometimes even towards the left jaw. Sometimes if you have ischemia involving the inferior wall of the heart, sometimes it can radiate even to the epigastric region. Pain of aortic dissection, it comes from the chest, retrosternal, goes back intrascapular, between the scapula, and it's a ripping pain. You might even have chest pain, maybe in the subcostal area. It's biliary pain. It's localized in the right upper quadrant, and sometimes it radiates to the shoulder. It mimics maybe chest pain. So sometimes severity can tell you. If the patient tells you the pain is very severe, it's sudden in onset, I've never felt this pain, and it's the worst ever, you should think of a myocardial infarction. You should think of something called pulmonary embolism. They're very sudden, it just comes, or even aortic dissection. So, for example, the timing and duration can do the damage to the heart. So, for example, stable angina. Stable angina means the angina that comes maybe during exercise, but when you're having rest, it doesn't come. Maybe you're around the house, it doesn't come, but maybe when you go walk a flight of stairs, you feel that pain. And it lasts less than 10 minutes. That is known as stable angina. Anything more than 20 minutes is known as is covered under the acute coronary syndromes. You can have unstable angina, you can have the myocardial infarction, and it's unpredictable. So look at the timing. If it's less than 10 minutes, especially 10 to 15 minutes and less, 10 to 15 minutes or less, that is stable angina. It's relieved mostly by nitroglycerin. But you have an acute coronary syndrome, when you have pain more than 20 minutes, it means there's compromised blood supply to the heart more than 20 minutes. So it means the pain will be severe, and there'll be some form of damage, some form of structural damage because of reduced blood supply to the heart. So you suspect the acute coronary syndromes. Let us look at the pain the pain that is associated with pericarditis. Pain associated with pericarditis, remember the outer layer of the heart is inflamed. Maybe you can have lupus, pericarditis, secondary maybe to lupus or other drugs. There's some drugs that can cause pericarditis. The pain is very classic. It lasts hours to days, so it's very long. And remember, this pain is positional. Positional means it is worse while lying flat. So these patients will tend to maybe relieved by sitting forward or even leaning forward. So chest pain that lasts hours to days, and is positional, that is worse while lying flat, relieved by sitting upright and leaning forward a bit, that is very classic pain of pericarditis, after you've ruled out respiratory and gastrointestinal pain. So always ask about all the other system. So the other thing you can ask about is the aggravating and relieving factors. So exertional triggers, is it triggered by maybe walking up a hill, walking a flight of stairs, going to the gym or something like that? So when there's exertional pain and is relieved by GTN, in these slides we'll be referring to nitroglycerin. So whenever you have pain that is exertional, means it's worse with exercise or activity, relieved by nitroglycerin, it suggests ischemia. Okay. And if it's not relieved by nitroglycerin, it means that you take the nitroglycerin, okay? You take the nitroglycerin and you still don't get relief. That could be a pain now of a serious condition, a more grave disease, which is myocardial infarction. Okay, myocardial infarction means the pain now lasts even up to half an hour, more than 20 minutes to half an hour. That is not relieved by nitroglycerin. That could be an underlying myocardial infarction. We talked about pain that is worse on inspiration, that is pleuritic pain. You think of pulmonary embolism, you think of pericarditis and all those kind of things. So what are some of the associated symptoms of pain that can tell you this is a cardiac-like pain? Always ask about, is there any sweating or diaphoresis? Sweating a lot together with chest pain that is not relieved by nitroglycerin could be a sign of myocardial infarction. They get lots of anxiety, they get palpitations. And because when you have a myocardial infarction, most patients will describe it as feeling of impending doom. Like I felt like I was about to die. That's because of that anxiety and how the heart is, they feel like they're about to die and they have very serious sweating or diaphoresis. You can have dyspnea. Remember, when you have dyspnea, it means difficulty in breathing. So how can you have dyspnea? For example, when you have left ventricular failure. Remember, once a certain organ starts failing, the organs before it, there'll be traffic jam of the blood. For example, let's look at circulation through the heart. It comes from the left side of the right side of the heart. It exits through the pulmonary artery. It goes to the lungs for circulation. And then it goes now through the pulmonary vein to the left side of the heart, where it's now pumped to the circulation. So if you have failure of the left side, it's not pumping blood forward. What will happen? Blood will pull backward to the lungs, and you'll get dyspnea, copious amount of pink frothy sputum, which is very specific for left ventricular failure. You'll start getting orthopnea, paroxysmal, any lung symptoms. Similarly, you can have lung pathology that affects the heart. For example, you can have maybe chronic TB, you get TB fibers, you get pulmonary arteries, and as a result, the blood going past the lungs very well. What does that do to the right side of the heart? The right side of the heart now is forced to pump against a higher resistance. Eventually, the right heart fails, and that is known as copulmonale. Sometimes you might just get right-sided heart failure. So remember, right-sided heart failure, what happens? Blood now starts pulling up in the preceding vessels. For example, when you have right-sided heart failure, the superior vena cava starts pulling blood to the neck. That's why you get distended neck veins. The inferior vena cava collects blood from the inferior parts of the body. You start getting ascites. You start getting portal hypertension. You start getting bilateral pedal edema. So just know, whenever you have something that's not working, it affects the upstream, above the obstruction of the pathology. So that's why patients with dyspnea, you suspect maybe it could be as a result of left ventricular failure or even like an acute coronary syndrome where the entire heart is not pumping well. You can get palpitations, and these are signs of arrhythmias. You can get syncope. Syncope means sudden loss of consciousness, and this is, you need to differentiate it from loss of consciousness that is related to the central nervous system. Because central nervous system, they wake up visibly confused. They don't know what happened. But cardiac patients are able to regain their consciousness, much faster, and it's much shorter, loss of consciousness that is related to the central nervous system. So causes of syncope could be aortic stenosis or even arrhythmias. Sometimes I told you might get inferior myocardial infarction, where you have chest pain that is radiating maybe towards the left side and everything, but sometimes it radiates towards the epigastric region, and sometimes you may get some irritation and you get some nausea and vomiting. So you can also get palpitations, okay? But then this one, it's very, it's very hard to just get someone who came with palpitations, but look at the onset. If it's sudden, you could be thinking of supraventricular tachycardia. If it's gradual, maybe it could be just sinus tachycardia. Look at the duration of the palpitations, like the heart beating fast, Is it in seconds, just a few seconds? Is it minutes? Is it hours? If it's hours, you feel that the heart is beating so fast for lots of time, that could be specifically to, more specific to, that could be a specific sign of atrial fibrillation. Sometimes they'll tell you, the palpitation, they're mostly aware of their heartbeat. And sometimes you could have triggers. What makes the palpitations worse? Is it relieved by rest? Is it relieved by nitroglycerin? Is it relieved by maybe doing a certain activity? And what makes it worse? Sometimes you might find palpitations that are triggered by caffeine. Some people just take coffee, they get palpitations. Sometimes systemic diseases like anemia, fever, and hyperthyroidism are known to cause palpitations. So sometimes palpitations can be associated with loss of consciousness, transient loss of consciousness called syncope. And this means this is a high-risk arrhythmia. So some of the red flags of palpitations is when you have palpitations, like your heart is beating so fast and you lose consciousness. And this could, be pointing towards ventricular arrhythmia. Okay, but then it's very rare to get someone with just palpitations. We mostly see it in the emergency settings and they're stabilized, but chest pain is something you should know. So you can get also syncope or presyncope. Syncope, I told you, is the sudden, transient loss of consciousness. You can have syncope because of cardiac problems. For example, I told you arrhythmias. You can get aortic stenosis, hypertrophic cardiomyopathy. You can have, because of reflexes, especially the most common one is the vasovagal reflex. Sometimes you might have syncope because of non-cardiac causes like orthostatic hypotension. For example, when you are hypovolemic. Remember our GI patient who was vomiting? Remember our GI patient who was diarrheaing? So they lose a lot of blood, they get electrolyte disturbances, they get hemodynamic instability. And because the circulating blood volume is low, what happens? Or even patients who are, post-road traffic accident, they lose a lot of blood, they have a lot of hemorrhage, maybe of 2 liters. So they are hypotensive. So the volume is depleted. Or some medications can also cause orthostatic hypotension. So maybe when they stand up from a sitting position, the blood, because of the gravity, it pulls down and you can get loss of consciousness. So when you get syncope that occurs during exertion, let's say someone plays football, is engaged in activity, he faints. This could be a sign of a cardiac related syncope. So for example, I talked about, it could be arrhythmias, it could be aortic stenosis, or even hypertrophic cardiomyopathy. You also need to ask, take a detailed family history to check any history of cardiovascular diseases, any history of sudden cardiac death, yeah. So if there's nothing, you just get syncope just suddenly, while you're not doing anything, you're just seated and you just fall down, and it could suggest it points towards an arrhythmia rather than the other causes like aortic stenosis or hypertrophic cardiomyopathy. So you can also get dyspnea. Dyspnea just simply means difficulty in breathing. And dyspnea, as a result of maybe cardiovascular pathology, it points towards left side of the heart failing. Especially, you can get orthopnea. Orthopnea means dyspnea when lying flat. So when you lie flat, you get dyspnea. That's known as orthopnea because of left ventricular failure. You can get paroxysmal nocturnal dyspnea. Paroxysmal means sudden, nocturnal, at night. Dyspnea means difficulty in breathing. You can get suddenly you just woken up in the middle of the night, you're short of breath. And this is because of the nocturnal pulmonary congestion of blood. This could also point towards left ventricular failure. Sometimes you might just get exertional dyspnea. Let's say you're exercising or you're just doing some small activity, you're brushing your teeth, you're getting dyspnea. That could be dyspnea because of heart failure or even valvular disease, but it could be left side, it could be right side. It means the heart is not doing, most specifically the left side. So the other thing patients can present with is edema. You can have ankle edema, sacral edema, you can have pitting or non-pitting edema, but most of the time they'll have pitting edema. And they'll also have abdominal other symptoms of congestion, especially if the right heart is affected. They'll have maybe portal hypertension, they'll have abdominal distension, they'll get ascites. And this points towards, remember I told you, once blood start pooling in the inferior circulation and in the neck, for example, you get ascites, you get pedal edema, you get distended veins in the abdomen, you get distended neck veins, you think of right ventricular failure. So you need to differentiate edema in terms of cardiac, renal, because the causes could be nephrotic syndrome, it could be heart failure, you might have end-stage liver disease, or it could you can be having varicose veins or secondary to venous insufficiency. So in all cardiac patients or in all patients, even the gastrointestinal patients, always do a past medical history immediately after your HPI, your past medical and surgical history. You ask about any pre-existing condition, because most probably by the time someone comes with a heart condition, they could be having underlying illnesses, for example, hypertension, diabetes, dyslipidemia. They could be even having a prior presentation or prior hospitalization because of myocardial infarction. Maybe there was an intervention, maybe, for example, percutaneous coronary intervention. Maybe they underwent some surgery, for example, coronary artery bypass graft surgery, those kind of things. They could be non-patient with rheumatic fever. So always ask about any pre-existing chronic condition. Even in your biodata, you ask after you've done your name, age, sex, occupation, marital status, residence, all those kind of things. You can ask about, do you have any chronic condition? They'll tell you one of these most probably. Sometimes it could be also having past hospitalization or past admission, as well as stroke. So drug history is, I keep on saying it's very important, because these patients will be patients on heart or cardiac patients will be probably on not a single medication, but multiple drug regimens. For example, they can be on beta blockers, ACE inhibitors, anticoagulants, all these kind of medications, even herbal supplements. Sometimes they might be taking some supplements from, traditional medication. So family history, the most important things you need to ask about is sudden cardiac death. For example, premature ischemic heart disease. For example, if you find maybe there's a patient, there's a relative who's less than 55 years old, or especially in males or in females, just take maybe less than 50. Anyone who's less than 50 and then is present in the family who also has similar, sometimes these symptoms, these diseases, cardiovascular diseases, tend to be genetic. You can ask about history of cardiomyopathies, especially sudden cardiac death or sudden collapse. You can ask about if there is any pre-existing genetic illnesses in the family. So social history always asks about smoking, alcohol. Most importantly, I want to highlight intravenous drug use, because intravenous drug use is a big risk for something called infective endocarditis. That one you don't have to miss this in exam. It's a very important topic, and you need to know infective endocarditis by heart. If you see a patient, you should know this patient. Oh, my differential, top of my differential should be, what are some of the signs you can see in patients with infective endocarditis? You can ask about their lifestyle habits, their physical activity, occupational exposures. For example, whether they worked in a factory, which kind of factory. For example, cobalt factory, people who work in cobalt factory without adequate protection, they most likely it has been linked. The people who work in cobalt factories have been linked to eventually develop some form of cardiomyopathy in later in life, based on some research studies. So this is a video showing cardiovascular exam. You can go through it. I'll send the video, I'll send the slides. So we're going now to start the cardiovascular exam. This is the simplest cardiovascular, it's the simplest examination, because there's a step it misses. So this one I'm talking about full cardiovascular exam. So always look at what the consultant or the stem of the question is asking you. So if you're told to do full cardiovascular exam, it means the heart and the peripheral signs. So you'll start with the inverted J, as we did in gastrointestinal exam. But if you're told to do just a precordial exam, precordial means in front of this, precordial, just in front of the heart. So you'll just do inspection, you'll just do palpation. Normally we skip percussion in CVS, and then you'll finish with auscultation and check the limbs for edema. But then if you're told to do a full cardiovascular, it means you look at the heart, you look at the vessels, you look for the peripheral signs. So let us look at the overall structure of cardiovascular exam. So similarly, you always do your gripe. The mnemonic is gripe. You greet the patient, create rapport, introduce yourself, seek permission, and you ensure the patient is exposed. Okay? So you go to the foot of the bed. Remember, to the foot of the bed, we said we describe how many things? 2 things. The patient's appearance and the patient's surroundings. So what are some of the pointers that can tell you this is a cardiovascular patient? Number one, they'll be having dyspnea or difficulty in breathing. Number two, they might be on oxygen, because of the difficulty in breathing. Number two, might be having orthopnea, so they can't sleep flat. So you'll find the bed is at an angle, mostly 45 degrees and above. They might be cachexic or wasted because of very poor feeding and loss of appetite. Sometimes they might be the opposite, or very obese. If a person is very obese, you suspect there could be an underlying comorbidity. For example, you can think about heart failure, maybe with preserved ejection fraction, maybe just heart failure. You can suspect this patient could be having heart failure, or this patient could be hypertensive. This patient could be having maybe an underlying disease, for example, diabetes mellitus syndrome. So they might be, maybe if the patient is sweating, say the patient is sweating, if the patient is in obvious distress, pain, or respiratory distress, always mention it. So always look, and this is like the typical cardiac patient, sometimes in the ward, especially if their condition is poorly managed. So number two, especially when they're being stabilized, once they come to the emergency, they'll be like this: bed is at an angle, they're on oxygen. The typical patient will be an old patient, those kind of things. So always look at the surroundings. Number one, oxygen. Always comment on the oxygen supply. Is it via simple face mask? Is it via non-rebreather mask? Is it via nasal prongs? How many liters? Go and read per minute. Surroundings, you might find maybe there's a nitroglycerin. The patient can be having maybe some medications that can point you towards cardiovascular pathology. Maybe they'll be having beta blockers, they'll be having calcium channel blockers, all those kinds of cardiac medication, beta blockers, ACE inhibitors, angiotensin receptor, all those kind of things. So you might, and always confirm, is the medication belonging to the patient or is it belonging to the neighbor? So the other thing you can check is for IV lines, comment on what the patient is receiving. Does the patient have a diaper or any urine bag or urine catheter? Once you see a patient with diaper or urine bag or urine catheter, what should come to your mind is that the patient is not ambulant or is not able to move and go to the toilet because of one reason or the other. You can comment on any chest tubes or drains you see on the patient. So after doing your gripe, you've moved to the foot of the bed. You've described the patient. You've described the patient's surroundings. You come to the hands. And what are you checking in the hands? General signs as well as signs of cardiovascular disease. So let us look at some of the signs. Number one, you can get finger clubbing. And I told you have to grade the finger clubbing from grade 1 to 4. And you have to know that finger clubbing is not only a sign of cardiovascular disease, it has a wide range of causes. So talking about grade of finger clubbing is this one. Grade 1 is nail bed fluctuation. You stabilize the nail bed and you check if the nail bed is fluctuating from side to side. Grade 2 finger clubbing is obliteration of the Lovibond angle or the Shamroth's window is absent. And then grade 3, as listed here, is parrot beaking. When you look at the fingers from a horizontal perspective, it looks like the beak of a parrot. So it has a very exaggerated curvature. And then grade 4 is hypertrophic osteoarthropathy, or maybe drumstick appearance, where now the actual distal bone, has become so hypertrophy and has, become wider than the proximal shaft. So these are the causes of finger clubbing. So go and just familiarize yourself on the causes of finger clubbing. But related to the heart, what can cause finger clubbing? One is cyanotic heart disease. Remember the truncus arteriosus, tricuspid, those stenosis, all the T's. Cyanotic heart diseases, they can cause finger clubbing. Number 2 is infective endocarditis. I told you infective endocarditis you must know because it is a cause of finger clubbing and it's one of the very big differentials you can think of in cardiac disease. So the other thing after finger clubbing you can check for is cyanosis, especially peripheral cyanosis in the digits, in the pulp of the fingers and around the nail bed. The other one is nicotine staining. Nicotine staining or tar staining. Because of the burns when holding cigarettes, some patients you can observe they might be having nicotine staining. The other ones is sign of hyperlipidemia. Remember, high cholesterol levels can also affect the heart because of the lipid deposits. And you have a increased risk of getting acute coronary syndromes and, angina because of the deposition of these fats, because of the elevated triglycerides, the harmful ones, which is the LDL syndrome. Remember the LDL, the low density? Those ones are very harmful and they tend to cause more harm. So you have increase of cardiovascular disease once you have them. If they appear in the hands, you can see it's called xanthoma. If they appear in the tendons, you can see this is tendon xanthoma. This is also a sign of hyperlipidemia. Pallor, this one you talked about it. Splinter hemorrhages. Once you see this, you should think of one thing, and that one thing should be infective endocarditis. The other thing you can check is Janeway lesions. Okay, Janeway lesions, I want you to note that they are painless. And where are they located? They are located mostly in the palms. Remember? So they're located in the palms and they're painless. It's also a sign of infective endocarditis. Osler's nodes, however, they occur in the tips of the digits. So you just palpate and check if you ask the patient, you palpate on these lesions, you just gently press, like the way you want to press for capillary refill, and you just press and you ask the patient, is there any pain? If they're painful, those are Osler's nodes. So one way to differentiate them is the location. Janeway lesions are in the palms. Osler's nodes are in the tips of the, are in the digits, basically. Osler's nodes are painful or tender, and Janeway lesions are painless. The other thing, you just gently bilaterally, palpate the hands of the patient. You see if the patient warm to touch, or if the patient is cold to touch. So they might be cold because of normal conditions, maybe anxiety. Maybe a student is sitting for exams. Maybe he's scared of the lecturer. You just feel anxious and your hands are cold. But then they could be as a result of also some pathology. For example, you can have as a result of peripheral vasoconstriction. Peripheral vasoconstriction means the peripheral vessels, especially the arteries, they constrict to reduce blood supply to the peripheries or to the limbs and give priority to the other organs. For example, the brain, the heart, and the kidney, the lungs, and the liver. Because this happens when you have reduced blood supply. What can make you have reduced blood supply? One, when you have shock. Any kind of shock. You can have anaphylactic shock and those kind of things. But there's some shocks that cause warm hands. There's some shock that cause cold hands. Here, for example, when you have hemorrhagic shock, for example, you lose blood. So the blood circulation is reduced, the blood volume. So blood is shunted towards the major organs and you will have peripheral vasoconstriction. The other one you can get is hypothermia. When you go to a very cold place, maybe away from the tropics, maybe you go to, the Western countries like maybe America, Canada, maybe it's winter season, your hands will be cold, or even in Kenya, during the cold season, your hands are cold. Because why? Your body is preserving the heat to prevent heat loss to the environment through the limbs. So your body's the core, the circulation is given the core of the body, like maybe the central part of the body, the trunk, is given preference in terms of circulation so that you don't lose a lot of heat to the environment. Anxiety can cause it, Raynaud's phenomenon can cause it, or sometimes you might find as a result the vessels are not constricted, the vessels are normal, but then you can have circulatory failure, like the pump is not working. One, for example, you can get it in cardiogenic shock. Another circulatory failure, we talked about it, is hypovolemic shock. When you have low volume of blood, secondary to maybe severe vomiting, severe diarrhea, or hemorrhage in road traffic accidents. So capillary refill time is another thing you need to check. You apply pressure to the skin. The best place to check for is the pulp of the finger and not the nail bed, because women tend to apply, things on the nails. So it's better you press the pulp of the finger and then you check how long it takes for the pallor to disappear and the color to return. So 2 seconds and less is normal. So anything above 2 seconds is increased capillary refill time. So the other thing is the pulse. In cardiovascular exam, you have to describe almost 6 aspects of pulse. One is the rate. The normal rate is 60 to 100. Anything more than that is tachycardia. Anything less than 60 is bradycardia. And these are the causes of tachycardia and bradycardia. Tachycardia could be fever, anemia, thyrotoxicosis, and some drugs, okay, beta agonist. However, bradycardia, you can see it in athletes, which is normal, especially very fit individuals. Beta agonists cause tachycardia. So beta blockers like propranolol, all the carvedilol, bisoprolol, metoprolol, all those things, they cause what? They cause reduced heart rate. So those are beta blockers. So they'll cause bradycardia. Hyperthyroidism causes tachycardia. Hypothyroidism will cause bradycardia. So go and check the causes of tachycardia and bradycardia. So after the rate, you have to check the rhythm. So the rhythm can be regular, which is normal. We call it normal sinus rhythm. Or you can have irregular. And 2 types of regular. You can have regularly irregular, or you can have irregular. I want you to note that just for exams and MCQs, when you have an irregular rhythm, it could be, it's very specific for atrial fibrillation, AF, okay? Don't forget that, irregular. However, you have a regular. So it could be, maybe you get sinus arrhythmia or second degree heart block, but don't forget the irregular, which is a sign of, could be an underlying sign of atrial fibrillation. So the other thing is the volume, how you feel the pulse. Is it normal? Okay. Is it above normal? Like you feel like the pulse wants to, it wants to come out of the vessel. It's bursting, it's pounding, it's hitting your finger so hard and so high. That's known as a high volume pulse or bounding pulse. You'll see it in fever, anemia, hyperthyroidism, aortic regurgitation, and those kind of things. However, when you have low pulse, like it's very weak, it's known as, in medical terms, they call it thready pulse. It means the blood that is coming to the periphery is a bit weak. It's not, it's not adequate circulation. You can see it in shock, when the pump is failing, heart failure, when you have cardiac tamponade, or maybe the outlet. Remember, blood comes to the outer, to the periphery. So when you have aortic stenosis, there is decreased output, and not as much volume is coming out as before. So you might have low or weak or thready pulse. So the other thing is the character. So go and look at the characters of how to characterize pulse. So, but I want you to focus on collapsing pulse. You have to check for a collapsing pulse where you palpate. There's a technique. You can watch videos online, because collapsing pulse could also be a sign of aortic regurgitation. Okay, never forget that. Collapsing pulse, most likely a sign of aortic regurgitation. Go and look at the techniques up. So the other thing is, you look at the image on the right. The clinician is palpating both pulses bilaterally. So these ones is to check for any delay. So always do it like this, because one, it will check for any delays. Number two, if you don't feel it well in one hand, you can feel it maybe in the other hand, and it will increase your chances of getting the pulse. Sometimes you might find it difficult to palpate for the pulse in one hand, but maybe if you check the other hand. So always do it bilaterally. When you get radial delay, you have RR. So the main cause of it could be subclavian stenosis. But once when you have radiofemoral delay, that is most likely as a result of coarctation of the aorta. So radial RR, think of subclavian stenosis, but radiofemoral, think of coarctation of the aorta. So the other thing you need to check, you need to comment on, is the vessel wall. The vessel wall most probably is soft, it's pliable, you can easily palpate it, and it's compressible basically. So you can say the vessel wall is pliable, but maybe in old individuals, you find that the vessel wall is like a plastic pipe. It's not compressible. That is known as rigid or tortuous vessels. Especially rigid vessels could be as a result of old age and because of calcification, elderly age. Atherosclerosis. It could be the result of long-standing hypertension and diabetes. And if you find the vessels are thick again and rigid or tortuous, it could be because of calcification of arteries because of old age. But in most individuals, the vessel wall will be pliable. So remember the rate, rhythm, the volume, character, the delays, and vessel wall condition. So this is collapsing pulse. So the character, when you're looking at the character, this is one of the things you look for, and it's seen in, I've put it in bold, it's seen in aortic regurgitation. So the technique is, you always ask for pain in the arm, you palpate for the pulse here, and then you palpate for, I think, the brachial pulse. I think this is the wrong technique, but at least you should palpate for the brachial pulse in the brachial artery, and then you ask for any pain, and you immediately lift the arm up. So normal individuals, you should still be able to feel the pulse even in the radial. You should be able to feel the pulse after this maneuver. Just when the arm is in this position, the pulse should still be present in the arm. But in patients, we call it collapsing pulse, because now the pulse that you feel, on the radial pulse now disappears, because the blood now collapses and blood settles here, maybe in the elbow, and you'll now start feeling the brachial pulse is pounding a lot. And that is known as a collapsing pulse. So what does that indicate? There is maybe aortic regurgitation. Sometimes it could be as a result of a high output state. It could be as a result of patent ductus arteriosus. But just know, collapsing pulse, aortic regurgitation. So the other thing you can do is measure your blood pressure in the arm. So remember, we we just to do a quick review so that you don't zone out. We did our gripe, created rapport with the patient, went to the foot of the bed, described the patient's surroundings. We started looking for peripheral signs in the hands, which we've covered it. Then the next thing is you describe the pulse in detail, at least six aspects of pulse, check for the collapsing pulse. Then here we are. Do the blood pressure. If you're able to have the cuff, well and good. So make sure the correct cuffs, the arm should be at heart level, the patient should be rested, not using the phone, not talking, just relaxed. So sometimes you can compare both arms. If you find more than 20 millimeters difference, it could be as a result of maybe an aortic dissection. Remember we talked about aortic dissection, the ripping, sudden pain. It goes back to the interscapular region. Yeah. And then it could be as a result of also subclavian stenosis. Okay. Yeah. So you comment on the pulse. So now we come to the head to toe approach from top to down. In the eyes, you can check for number one, you can check for pallor. Okay. Number two, and pallor can be as a result of anemias. For example, iron deficiency anemia, megaloblastic anemia, hemolytic anemia, and all those kind of anemias. So number two, we check for is jaundice. Okay. And jaundice, I told you, it could be as a result of hemolytic anemia, especially the most common prehepatic cause is hemolysis. So when you have lots of hemolysis, you can get hyperbilirubinemia and you can get scleral jaundice. So this is just another image, the exact copy that we did in the gastrointestinal tutorial. So this one, you go through it, and I've also put the same video of jaundice because it's a high-yield topic on the types of jaundice, the pathophysiology, causes, and treatment. So in the eyes, same things. We can look at signs of hyperlipidemia. On the left here, we have corneal ACAS, especially when you see it in young individuals, less than 50 years, you think of maybe an underlying hyperlipidemia or underlying disorder of cholesterol or lipid metabolism. This on the right here is xanthelasma, like when you have lipid deposits in the eyes. Because remember, when you have too much lipids deposit in the skin, they also deposit in the arterial walls. You can get those, atheromas, and it can predispose you to getting myocardial infarction. So in the eyes, I think this is for registrars. Sometimes you can have a fundoscope. You check the retina. Sometimes you might have features of hypertensive retinopathy, but we don't check it as undergraduates, But ideally, you should. But then it's just that we are in a very resource-limited setup and nobody has access to the fundoscopy. So remember, in the eyes, you look at pallor, jaundice, and signs of hyperlipidemia. So in the mouth, what are some of the signs in the mouth that you can check that can point us towards cardiovascular disease? One, you can get central cyanosis. Number two, we can get pallor, central pallor of the tongue and the lips. You can get oral thrush. Whenever you see oral thrush, it's a sign of immunocompromised patient. A sign with a patient maybe who has HIV. This is a patient who has maybe diabetes. This is a patient who is using lots of steroids, especially maybe systemic steroids, as well as maybe a respiratory patient who's using lots of inhalers and is not maybe he's not gargling or he's not rinsing with warm water. Those inhalers have steroids. For example, budesonide, it deposits on the oral mucosa and you get predisposed to getting candidiasis and such infections and oral thrush. Some antibiotics as well can cause that. Oral ulcers. Okay, oral ulcers can be a sign of an underlying systemic illness. For example, we talked about inflammatory bowel disease, SLE. Remember, SLE can affect any system. It's called systemic lupus erythematosus. It can as well cause oral ulcers. So the other thing I want you to pay attention to is dental hygiene. You can see these two images. You tell the patient to open their mouth, and you even check the back of the teeth. I mean the molars, the premolars. You'll find that there is poor dental hygiene. One, you'll see maybe there is periodontitis, halitosis or bad breath, poor oral hygiene. This suggests that this patient could be having diabetes or immunosuppression, but most probably, which is relating to the cardiovascular system, this patient has a high risk of getting something called infective endocarditis. Remember, this poor dental hygiene is because of bacteria. So any injury, remember this teeth has a lot of bacteria there, especially, for example, Streptococcus species. So what happens? Maybe the patient maybe brushes the teeth after a while, or maybe undergoes a dental procedure, maybe without adequate antibiotics, or just any injury. Maybe he uses a toothpick. What happens? The mouth, there's some vessels. So those bacteria enter through those vessels and eventually circulate and come to the heart. And that's why these patients have high risk for infective endocarditis. And it's called endocarditis because it affects the endocardium. And what lines the heart? Apart from the endocardium, it's the valves. So it affects the endocardium, most probably the valves. So go and read about infective endocarditis as well as rheumatic heart disease. You need to know those two things, and heart failure. So this is glossitis. They can have glossitis, you can have angular cheilitis. This is just because of anemia, because anemia presents as it can lead to heart failure. You get those bounding pulses and those kind of things. So angular cheilitis, you can get high act palate, and this is very classic for Marfan syndrome. You see the palate, instead of it flat, it's it's like a groove. It's very high, and this is associated with conditions like Marfan syndrome. So in the neck, so remember, we've done the eyes, we've done the mouth, and then make sure the patient is at 45, the head is slightly turned. You have to identify the internal jugular vein. That's the first thing, because you might have pulsations from the carotid artery. So you need to differentiate. The internal jugular vein, it is pulsatile, but once you palpate it, it's non-palpable. You can see it pulsating visibly, but it is non-palpable. However, the carotid, when you palpate it, you will feel the pulse, just as you would have felt for the pulse of the radial artery. And you measure. There's a technique for measuring. I've attached a video here. You can watch the video at your own time. So you measure the vertical height above the sternal angle, and normally it should be less than 3 centimeters, totaling to about less than 8 centimeters. Any elevated JVP, I told you, distended neck veins, it could be a sign of heart failure, especially what? Right-sided heart failure. You can get as a result of fluid tamponade. Cardiac tamponade, or even fluid overload. So you can get fluid overload, cardiac tamponade, and heart failure, specifically, most probably, either global heart failure or right-sided heart failure. So you might find something called Kussmaul sign. This is just for your MCQs. It's a paradoxical rise. Remember, the internal jugular vein, when you inspire, what happens? The lung expands. When the lung expands, the resistance in the lung reduces. So lots of blood comes to the lungs. So ideally, once you take a deep breath or during inspiration, the neck distension should reduce. So when you happen to see that during inspiration, there is a paradoxical, or there is a unusual rise, quite opposite of what we expect in the jugular venous pressure. That is known as Kussmaul sign, and it is seen in conditions like pericarditis and restrictive cardiomyopathy. So if you're not able to do, if you're not able to check for JVP, or you can't be able to appreciate any pulsation of the internal jugular vein, you can do hepatojugular reflux. Okay, you can try to press maybe the liver to check for any rise in JVP. So you can also another JVP abnormality we talked about is distended neck veins. You can see it in superior vena cava obstruction. You can see it in restrictive cardiomyopathy. You can see it in pericarditis, tension pneumothorax, and those kind of things. So just know distended neck veins, when you're looking at the heart, it is because of most probably some heart failure, or it could be as a result of some pericarditis or something surrounding the heart and compressing the heart. For example, cardiac tamponade, or even tension pneumothorax. So this is a video I've attached showing measurement of JVP, and this is another second video I've attached measurement of JVP. So you open this presentation using Microsoft PowerPoint, and not any other app, because PowerPoint you tend to watch the videos visually. So remember, we've done the peripheral signs. Now we come to the precordial exam. So remember, we were doing the complete cardiovascular examination. Now we've come to the precordial. If you're told to do precordial exam, you only do 3 things. You do inspection, you do palpation, you skip percussion, and you go to auscultation, and you finish with just checking with for pedal edema in the limbs. So the precordial exam, I'd like to make it very simple. Number 1, you have to go to the foot of the bed in inspection. So what are you inspecting at the foot of the bed? you can comment about scars. Number 2, for example, you can have a sternotomy scar along the sternum, or you can even have a pacemaker device. Pacemaker device, it normally looks like a button battery, a round device, probably maybe in the second left intercostal space or somewhere just around that. You'll notice that there's a device implanted beneath the skin. So number 2, after the scars, you comment about the precordium, like the area around the apex or the heart. How does it look like? If it's normal and there's nothing wrong with it, that is known as a normal active precordium. Okay, sometimes you might get visible pulsations under the skin, just above the heart, and this is called a hyperactive precordium. Okay, number 3 is deformities. You check for any obvious deformities, whether there is any pectus excavatum or any pectus carinatum. So the next thing now, after you've done that, so remember, we're checking for scars, precordium, and deformities. So here in palpation, we palpate for 4 things. Remember, we were inspecting for 3 things. We were inspecting for scars. We were inspecting and mentioning how the precordium was, whether the normal active or hyperactive. Then number 3 was deformity. So in palpation, remember, we are palpating 4 things. So number 1, you're palpating for the apex beat. So remember, you have to scan around the chest. You can just point. You have to scan with your, with your palm, with your digits, and then you finally point. And where is the apex beat? To the 5th intercostal space, mid-clavicular line. And you have to say the characteristic of the apex beat. Sometimes you might have a tapping. It just taps. You feel a tap under your finger, tapping and going, tapping and going. That is classic for mitral stenosis. Sometimes you might have heaving. Heaving means it just pushes your finger above. It's like lifting your finger. It's pushing, but it's not throwing it up in the air. So it's just going up and down, up and down, up and down. And that could be a sign of, especially if you feel it in the apex, could be a sign of left ventricular hypertrophy. Hypertrophy means there is pressure overload. Sometimes you might have thrusting or hyperdynamic apex beat. Thrusting means, remember the word thrusting? You're pushed up in the air. So the finger is pushed and the finger lifts off the skin. So it's thrusted up. And that is classic for volume overload. And once you think of volume overload, think of the regurgitation. Think of mitral regurgitation. Think of aortic regurgitation. If it's non-palpable, it could be as a result of maybe something that is blocking you and the heart and the apex. So it could be as a result of obesity, lots of subcutaneous fat, effusion, for example, a massive pleural effusion, or even chronic obstructive pulmonary disease where the patients normally have this physique or, this appearance of barrel chest. So the chest is so wide. The anteroposterior diameter is so wide. So number 2 is heaves. So heaves you have to check for. It's normally, this is the technique here, but the elbow should be the elbow should be stretched, and you put the hand parallel to the sternum like this, and you feel for a heave, and it's called a left parasternal heave. So you're parallel to the sternum and you're on the left side. And the hand is slightly towards the left side of the patient. So whenever you have a left parasternal heave, remember heave, I told you it's what? There's a difference between heave and a lift, or heave and a thrusting. Heave means there is hypertrophy. Thrusting means there is dilation or volume overload. So whenever you feel for a heave, you feel it, and you feel it normally using the palm, especially the proximal part of the palm. You'll feel that there's a lift, and that is classic for a right ventricular heave, and it could be pointing towards the right ventricular hypertrophy or even some form of pulmonary hypertension. Remember, we talked about heave. We already talked about heave in the apical area. This one, we don't need to do it again. Apical area, when you have a heave there, it's left ventricular hypertrophy. But once you have an apical area, you find that there is a lift or a thrusting. Remember, that is volume overload. Yeah. So the other thing you need to palpate for is thrills. And thrills, you have to know the 4 valvular areas. Starting with the mitral area, you check for any thrills. Thrills are palpable murmurs. So aortic area is on the right, second intercostal space. Pulmonary area, okay? Then the tricuspid area is normally the 4th intercostal space, left lower sternal edge. Then the mitral is at the apex, where the 5th intercostal space, mid-clavicular line, is the abs point, where it's a good place to listen for all the heart sounds, but just ignore it for now. But palpate for thrills in the valvular areas. And just know, murmurs are graded in from grade 1 to 6. Any mama that is grade 4 and above, it means that once you are able to palpate, just know maybe you're palpating maybe in the aortic area. We find that there's a vibration or a thrill. Thrills are just like vibration. It's like you're palpating your phone and you hear a small vibration beneath your hand. And remember, for thrills, you're using the palm, but then we just where the digits come out, the digits start to come out. That's where we do the thrills. We listen for, we feel for thrills. So thrills are palpable mamas, and once you're able to palpate the thrill, just know that mama is grade 4 out of 6 and above. So grade 5 out of 6 mama, the consultant may tell you to grade mamas. Once you're able to feel a thrill, just know that's a grade 4. If you put your stethoscope just slightly, okay, just slightly in contact with the skin, and you're still able to hear the mama, and you're able to, even after feeling for the thrill, that's a grade 5 mama. If you're able to listen to the mama with a stethoscope just not in contact, just close, but not in contact with the surface of the heart or the valve, it means that is a grade 6 mama. And it's so loud that you don't even need the stethoscope to touch the patient. So we finished grading of grade 4. Grade 4, it's palpable. Grade 5, palpable, and just when the stethoscope is in contact with the skin, you're able to listen to it. Grade 6, when the stethoscope is not even in contact with the patient's skin, and you're able to listen to it. Okay. So what about grade 3 and grade 2 and grade 1? So grade 3, you're able to listen with the stethoscope. Let me just break it in simple terms. You're able to listen to it with the stethoscope, but then it's non-palpable. When you palpate it, find a mama. But once you put the stethoscope, you are able to feel for it. Okay. And then the last grade is, that's grade 3. Grade 2, it's the mamas that are listened to by registrars. So you might be finding it difficult to listen to it as an undergraduate. So if you feel the registrar has felt a mama and you haven't felt, just estimate and say that's grade 2 mama. And then grade 1 is the consultant. The experienced people are able to find the grade 1 mamas. Maybe even a registrar might miss, but then the consultant. So grade 1, listened by a consultant. Grade 2, registrar. Grade 3, you're able to listen to the mama as an undergraduate, but you're not able to palpate it. Grade 4, you're able to listen to it as well as you're able to palpate it. Grade 5, you're able to palpate it, and you're able to So grade 4, you're able to, it's any palpable mama. Grade 5, when the stethoscope is just touching the skin and you're able to listen to it. And grade 6, when the stethoscope is just not in contact with the skin. So the number 4, you have to palpate for, you can palpate for the tracheal position. Is it central or shifted to the left or right? So has the trachea deviated, or is the trachea being pushed, or is the trachea being pulled? I think this one will be covered by my colleague who will be doing the respiratory system. So percussion, you don't do it in exam. Okay. The another thing I want to talk about is the angle of Louis. Angle of Louis is formed between the manubrium and the sternal body. There's normally this bump here, and just know it is parallel to, it's just next to the second rib. And it's not, I'm not saying second intercostal space. It's at the level of the second rib. So the space just below it. Okay, below. It's supposed to be below the angle of Louis or the manubrium, that angle. Just space below, just know it's parallel to, it's just next to the second intercostal space. So here, on both sides, you should be able to estimate that this is your aortic area and this is your pulmonary area. And then the rest of the ribs you can count in. You get your fourth intercostal space where you get the tricuspid area, and then the fifth intercostal space, mid-clavicular line, you can get your mitral area. So for auscultation, remember when you're auscultating, you have to use both the diaphragm and the bell of the stethoscope. So what is significant over the other? The diaphragm, it is used to listen to the heart sounds, the lab dub, S1, S2, S1, S2. And remember, S1 is louder than S2. Okay? The bell, it's very good in the small part of the stethoscope, it's very good in detecting the mamas. And that's why we listen to the S1, S2 in all valvular areas using the diaphragm. And we listen again with the bell to check for any mamas because the bell is good in detecting the mamas. So you listen to the areas which I've highlighted again. The aortic, second right intercostal space, pulmonary, second left intercostal space, the tricuspid, which is in the fourth intercostal space, the left cloasternal edge, and the mitral area, which is in the fifth intercostal space, mid-clavicular line. So what are you listening for? Number one, you should be able to listen to the heart sounds, which is S1, S2. You can listen for additional heart sounds, but this one, just ignore it for your level as fourth years. But then you should be able to listen to S1, S2, which means lab dub. Like the lab dub. Number two, apart from the additional heart sounds, you should listen to the mamas. So remember, I said use your bell, use your diaphragm. Remember, one hand should be on the stethoscope like this, like the way this lady is doing, but then one hand should either be on the radial pulse. Remember the radial pulse? Yes. But Hutchinson's recommends one hand to be on the carotid pulse because carotid is much closer. If the mama comes in sync and it comes every time you feel a pulse on the other hand, that's a systolic mama. Okay? Systolic mama means it comes during systole. And what happens during systole? In systole basically means contraction of the ventricles. When the ventricles contract, I want you to imagine the heart, the way the anatomy of the heart is. The right and left ventricle never contract independently. They contract as a unit. So they contract both. The right side of the heart pumps blood to the lungs and the left pumps to the systemic circulation. So what happens to the valves? When the ventricles contract during systole, the valves, the tricuspid valve and the mitral valve should shut. I want you to pay much attention to this. Just visualize it. When the ventricles contract in systole, the mitral valve and the tricuspid valve should shut. So if there is any reversal of blood, that is known as tricuspid regurgitation, as well as mitral regurgitation. Hence, mitral regurgitation and tricuspid regurgitation are systolic mamas because they're mamas that happen during systole. Let's look at the other hand. Let's look forward now. Where during systole or ventricular contraction, the aortic valve and the pulmonary valve should be wide open to allow blood to go to the lungs and the systemic circulation. If you have stenosis or narrowing, what will happen? There'll be turbulent flow, and as a result, a mama will be produced. So, aortic stenosis and pulmonary stenosis are systolic mamas. So I want you to imagine that, and you'll never forget mamas. You'll never know whether it's systolic or diastolic. You'll never forget whether it's systolic or diastolic. But just to be safe, always know systolic mamas. Once you palpate the carotid artery, one hand on the stethoscope and the bell. Remember using the bell to check for mamas. One hand on the carotid. If the mama happens every time the heart beats on the, if you're able to palpate for the heartbeat and they're in sync, they come together, that's a systolic mama. Okay? And systolic mamas, because they happen in systole, remember I told you S1 is louder than S2. So you'll feel the S1 sound becomes obscured by the mama, and you'll hear more of the S2. So you'll hear the mama, then S2. Do, do, something like that. So that's systolic mama. Systolic mama, you'll feel the mama like a vibration, then do, which is the dub. Okay? That's how systolic, even from how you listen to it, the pattern. So let us look at diastolic mamas. So diastolic mamas means when you're palpating the carotid, you'll feel like the pulse goes away. You're not able to feel for the pulse, but then you feel for the mama every time the pulse is non-palpable. So that's how you know diastolic mamas. Another way is from how it sounds. Diastolic mamas, since they come after diastole, so you'll hear lab dab ju, ju being the mama. So you'll hear dudu ju, like lab dab ji, lab dab ji. Okay, that's one way you can also know. But always use one hand on the carotid. Some consultants prefer the radial, but Hutchinson's prefers using the carotid artery. So whenever you have a mama, number one, you need to say where is the mama loudest? In which valve of the 4 areas you need to know. Number 2, I told you is the timing. Is it systolic or diastolic? Number 3 is the radiation. Remember, you need to check if the mamas are radiating. And there's some mamas that are specifically known to radiate to certain areas. For example, a mama of mitral regurgitation. What mama is that? We said it's a systolic mama. Because in systole or ventricular contraction, this valve should be shutting. It's reversing blood, so that's mitral regurgitation. So it goes to the axilla. So you have to follow with your belt till the axilla, and you tell the patient to slightly lean on the left. You do those maneuvers. Tell them to lean on the left, and you tell them to exhale. Okay. Number 4, you can maybe talk about the quality of the pitch, but then this is not very important. But the number 5, you need to grade. And I told you it's graded 1 to 6, and if a 3 is present, that's grade 4 and above. Number 6 is accentuation. You need to do, if you're able to, if you want to confirm that there is no mama or there's a mama, you need to accentuate. There's a technique you can do to make the mamas louder. Remember, right-sided mamas, a mama of the pulmonary valve, as well as mamas of the tricuspid valve, they get louder with inspiration. So if you want to hear them louder, you tell the patient to take a deep breath in and hold, because it increases return to the right heart, and there's lots of blood supply, lots of turbulence flow, and you get lots of loud mama. The mama becomes louder. But left-sided mamas, a mama of maybe mitral regurgitation, mitral stenosis, aortic regurgitation, aortic stenosis, they get louder with exhalation because there is increased blood flow to the left heart. So for example, if you're checking for radiation, remember we just said radiation, let's just go back there. Mitral regurgitation, it radiates towards the axilla. So if you want to check it, and if you want it louder, you tell the patient to exhale and hold there during a point of maximum exhalation, and you slightly lean towards the left. You follow it to the axilla, you'll feel it, it's still loud. Mama of aortic stenosis, remember aortic stenosis is the one that radiates superiorly because of the letter S, that you can remember it. Aortic stenosis, it radiates superiorly to the carotid. So if you want to hear it better, you tell the patient to exhale and lean forward. So the thing is ejection, clicks and snaps, but this is not for this is not for your level, but you can feel maybe for very advanced maybe registrars, they can be able to listen to ejection clicks, mid systolic clicks, and opening snap. But then I just want you to know this for CQs. If you're able to master this, just master it. When you have an ejection click, that is maybe aortic or pulmonary, it means there's obstruction going up, during systole. So it's a sign of aortic or pulmonary stenosis. Mid systolic click, this one you have to know for exams. Whenever you see an MCQ that says on auscultation there's a mid systolic click, in between systole is a click. That is very important for a pointer for mitral valve prolapse. And then opening snap. Remember we talked about mitral tapping apex bit. It also has something called opening snap. So whenever you hear snap, stenosis. Okay. Mid systolic click, mitral valve prolapse. Ejection click, you have clicking or maybe an obstruction when there is ejection or during systole. That is aortic or pulmonary stenosis. You might find you might feel for a pericardial rub, but then just focus on S1, S2 in all the valves for your level, and focus on the mamas. And mamas, you have to describe them in all the 6 the site. Is it systolic or diastolic? Is there any radiation? Have you done any accentuation? Have you graded the mama? And you can comment on the quality of the mama. Okay. So pericardial rub basically is a high-pitched, scratchy sound because of the inflammation of the heart. It's normally like leathery sound. It's best heard with the diaphragm, and then the patient is leaning forward. And it's normally both in systole and diastole. So the last thing you also need to auscultate for is lung basis for any signs of pulmonary edema, those crackles, especially cause crackles. So in simple terms, inspect for 3 things. CAS, comment on the precordium, as well as check for deformities. Number 2 is palpation. Palpation, you palpate for 4 things. You can palpate for the apex bit. You check whether it's displaced, and you comment, is it tapping? Is it normal apex bit? Is it tapping? Is it heaving? Is it thrusting? Number 2, tracheal position. Is it central or is it deviated? Number 4, thrills, and thrills are palpable mammals over all the 4 valvular areas. And then you check for the right parasternal heave. You skip percussion because we don't do percussion in precordial exam. And then you go to auscultation. Auscultation, basically, you for your level, you need to know auscultation of S1, S2. You should be able to hear S1, S2 in all the valves. You need to use the diaphragm when you're doing that. You repeat with your bell to check for murmurs with one hand on the carotid artery. And when you get murmur, you have to describe whether the site, timing, whether it's systolic or diastolic. Okay. You can grade the murmur, you can accentuate, you check for radiation. Okay, all those kind of things. And then the last thing, which is number 3, you auscultate for is the lung basis for for pulmonary edema. Then lastly, you check the foot for both pedal, for bilateral pedal edema. And remember, when you have bilateral pedal edema, it doesn't mean the heart only. It could be as a result of chronic liver disease or end-stage liver disease or liver cirrhosis, as well as nephrotic syndrome. So this is a summary of the precordial examination. So you have to do inspection, you do palpation, you do auscultation. Remember, we skipped percussion because we do not percuss the cardiovascular system. And then in lung basis, we check for crackles or signs of pulmonary edema, and we do edema, peripheral edema, especially checking for bilateral pedal edema. So key takeaways for this cardiovascular exam: use structured approach, especially for the precordial exam. Always do your inspection, palpation, skip percussion, and you go to auscultation in that order. Apex key, because it can tell if it's displaced, it means there's a cardiomegaly, or maybe situs in or dextrocardia. If it's heaving, remember it's heaving, it means there is left ventricular hypertrophy. If it's hyperdynamic or thrusting, it means that there is volume overload or left ventricular dilation. There's lots of volume. If it's tapping, it tells you that is mitral stenosis. It can give you the immediate diagnosis. So heaves and thrills are signs of advanced disease. And I told you, thrill is a palpable murmur more than grade, and it means it's grade 4, at least grade 4 and above out of 6. So auscultate all the valves. Okay. Remember, don't just do the apex bit, do all 4 valvular areas. You check for 2 things. Number 1, S1, S2. Is it present? The lab dub. Number 2, you repeat with the bell now. With one hand on the carotid, you check for any murmurs. And I told you describe the murmurs in 6 ways. And then lastly, remember, you're using also the left lateral decubitus position to check for maybe mitral regurgitation or mitral stenosis, and you tell them to slightly exhale, the accentuation maneuvers. Aortic regurgitation, remember aortic stenosis, you tell the patient to inhale and then exhale and hold during point of maximum exhalation. And remember, aortic stenosis radiates superiorly to the carotids. However, aortic regurgitation, it radiates downwards towards the abs point and even the tricuspid area. So it radiates a bit down. It's known as an Austin Flint murmur. Okay, it goes down, it radiates down, but aortic stenosis radiates superiorly. Mitral regurgitation radiates towards the axilla. So don't forget those. So always check the lung basis for signs of heart failure, for example, pulmonary edema, and always check the feet for bilateral pedal edema. And you summarize your findings. And that is all. And I wish you success in your examinations. Feel free to reach out. Make sure you sign up for any upcoming, pace medicine tutorials. And I think if there's no questions, I think that is all. So we'll have more sessions upcoming, which involves tomorrow evening, which is on Saturday evening, as well as Sunday evening, which